Okay, so welcome to our webinar about the policy options to improve access to memory care for dually eligibles. We are presenting the design and the initial finding of a 5-year study that is supported by the National Institute on Aging. My name is Soeren Mattke. I'm the principal investigator of this study. I'm a physician and health services researcher and a professor at the University of Southern California, where I direct the USC Brain Health Observatory. The Brain Health Observatory conducts research on brain disorders, right now predominantly on Alzheimer's disease and dementia, and we conduct country studies on health systems preparedness for memory care and health services and econ studies on treatment of brain disorders like financing, technologies, care pathways, and such. We are publishing all the data that we collect on care infrastructure, and of course, all projections and publications that we have are accessible through our website. So just for your orientation, it is a relatively brief presentation so that we have sufficient time for Q&A. We also kept it deliberately non-technical so that we can talk about the policy implication, the ideas behind the design, as opposed to modeling considerations and whatnot. But if you are interested in such details, we can address that in the Q&A. Also, Tabassa, who is on the call, who is the project manager for this project, will monitor the Q&A submitted through the chat. But if you have any questions, interrupt me or save them for the end and just raise your hand and I will call you up and take your questions. So this, like I said, is the study that we will discuss today. It really focuses on a particular disadvantaged group among the Medicare individuals, and those are those who are dually eligible for Medicare and Medicaid. The dually eligibles, or duals, how they're often called, are about 10 million individuals, and about 2/3 of them are in the Medicare old age range of 65 plus. But as you see, there's also about 1/3 of the full benefit duals who are not in the Medicare age range, and those have become eligible through disability in earlier years, and they can also be dually eligible for Medicare and Medicaid. So it's entirely possible that somebody aged into the 65 plus range while already be qualified for Medicare and Medicaid. And in addition to the full benefit duals that we will discuss today, there's also the partial duals that have some benefits that are not covered by Medicare, but not the full Medicaid range of benefits and services. So why the question of duals and the access to memory care issue? The reason is that dually eligibles have a higher burden of dementia, and that has two main reasons. First, they have a higher prevalence of risk factors for dementia. If you have read the Lancet Commission report, the risk factors for dementia mirror the ones for cardiovascular disease, like diabetes, hypertension, hypercholesteremia, things like that. And in addition, some other aspects, like particularly low educational attainment, social deprivation, and things like that contribute to the risk of dementia. And those, of course, are also prevalent in a poor population that becomes dually eligible. Moreover, the conditions are not just more prevalent among duals, but they tend also to be more poorly controlled. So HbA1c control, blood pressure control, cholesterol control, medication adherence tend to be all worse among duals than among Medicare-only beneficiaries. And the result is that they have a really very high burden of cognitive impairment. Like over 20% of the dual 65 and plus are estimated to suffer from dementia, and that compares to only about 8% in the Medicare-only group. So a really big difference in prevalence. But at the same time, because duals tend to have obstacles to access to medical care, in particular to elective specialty care, the detection rates are considerably lower. So if you look at MCI, this is from an earlier publication of ours, mild cognitive impairment, so the earliest manifestation of cognitive impairment, about 5.6 of the duals have been diagnosed. And Medicare, the rate is 8.5. Still not great, but considerably higher than among duals. And the detection rate for manifest dementia is about 85% in the dually eligible population and 120% in the Medicare-only population, which seems to suggest that dementia is underdiagnosed in duals and overdiagnosed in Medicare only. However, we need to qualify that these rates are based on a dated algorithm that we used. This was the algorithm of the chronic conditions warehouse that CMS recommended back then. It was since modified, and the dementia detection rates went down well below 100%. So that seems to be a better algorithm, but the gap between duals and non-duals remains the same. So there's also the problem that duals, while more burdened, are less likely to get treated for Alzheimer's disease. Many of you may have heard that there are now these disease modification treatments for Alzheimer's disease that can be used in the early stages of cognitive impairment and slow down the progression of cognitive impairment if patients are treatment eligible. We looked at the Medicare fee-for-service data up to 2023, which is about 3 years into the FDA approval of the first of these treatments, and we found a total of 924 patients in Medicare fee-for-service that went on these treatments. A really, really low number, by the way, given how prevalent this condition is in the elderly. But of these 924 patients, only 1.2 were dually eligible, yet dually eligibles represent about 8.8% of the total 65 and older Medicare population, and as I had pointed out earlier, a much larger share of the cognitively impaired population. So this study already points to the problem that dually eligibles are not detected in a timely manner, are not evaluated whether they are eligible for a treatment, and thus are more likely to miss out on a treatment that can slow down their progression of cognitive impairment. So why is this such an important problem for state policymakers? Of course, like with any medical condition, it is always better to diagnose earlier and more accurately, because even if you cannot treat a condition, patients have a right to know what they have, and they also need to know what they have and what explains their symptoms so that they can organize their lives around it, even if you cannot change the course of the disease. In dementia, particularly, you have to consider important life decisions like financial security, because we know that individuals with early stage cognitive impairment are susceptible to financial scams. Organize things like estates, living will, and all these things. We also know that management of risk factors for cognitive impairment can at least somewhat slow down the progression of the disease and maintain independence and cognitive ability for just a bit longer. And then, as I mentioned, there is the potential treatment indication for disease-modifying treatment. And then there's a very selfish reason for policymakers at the state level to be worried about access to memory care for duals. The reason is Alzheimer's disease is the most common cause of cognitive impairment, accounts about for half of early stage and about 3/4 of late stage cognitive impairment. The treatment of Alzheimer's disease, such as the diagnostics and the disease modification treatment, are mostly covered by Medicare because they are medical benefits. But downstream consequences of untreated dementia means often nursing home admission, which for duals states pay in full, and very few individuals have the financial means to actually pay for long-term care for more than a year or two. So sooner or later, individuals will become Medicaid eligible. And with rates around $90,000 per year, this is a substantial burden on Medicaid budgets. So we did a study a while ago where we projected how much Medicaid could save, and really literally save in terms of bankable dollars, with a disease-modifying treatment that reduced the progression of Alzheimer's disease. And we estimated that this could be up to 123 billion over a 20-year time frame from 21 to 41. The details and state-by-state numbers are in the below publication. So what we want to do in this project is we want to decompose the differential impact of three potential barriers that emerge for dually eligibles. And those are the administrative complexity, the lower payment rates under Medicaid, and then the lack of the benefit coordination between two different payers. So first about the administrative complexity. For dually eligibles, Medicare remains the primary payer for medical services, but Medicare, as you know, has substantial co-payments, such as a 20% cost sharing with no upper limit in traditional Medicare, which obviously individuals in the Medicaid eligible range are unable to meet. So Medicaid covers the cost sharing requirements for duals, and also like Part B premiums and deductibles in Part A and all of that. But this means that clinicians need to participate both in Medicare and Medicaid, which is already an administrative requirement, and they also have to submit two separate bills for a dually eligible to get full reimbursement. The bill to Medicare for the 80% that Medicare covers for physician services, for example, and then a separate bill to Medicaid for the co-payment. And that process can be complex and time-consuming. And as a reluctance, physicians tend to view dually eligibles like Medicaid only patients and are more likely to not accept them into their practice. And if you look here at the number, Medicaid eligibles are about 15% less likely than Medicare and about over 20 percentage point less likely than privately insured patients to be accepted as new patients by physicians. These are big differences, and in particular important is that the difference is larger in what we call elective specialty care. Primary care tends to be reasonably accessible, partly because of the federally qualified healthcare centers, charity care, and other community-based organizations. But specialty care is a different animal. It's much more selective, it's much more plannable, and private practices often either do not accept Medicaid at all or restrict the number of Medicaid individuals in their practice. The second reason is that the payment rate for dually eligibles may be lower than that of full Medicare patients. So states have the option to not pay the full Medicare cost sharing amount, but can adopt the so-called lesser off policy, and then they can pay the lesser of the Medicare cost sharing amount or the difference between the Medicare and Medicaid payment rates. So as a quick example, if a physician office visit costs $100, Medicare pays $80, and then Medicaid would pick up the $20 copayment. However, if the Medicaid rate for that office visit were only $90, Medicaid would only pay the $10 of the copayment. And obviously the physicians are not allowed to balance bill those poor patients. So if the Medicaid rate is lower than 80% of Medicare, physicians are not getting any of the copayment at all. Thus, a dually eligible is, on top of the administrative complexity, financially less attractive than a Medicare-only patient. And it's very common, like 41 states have adopted the lesser-of policy for physician services. And so it is a sort of added obstacle on top of the complexity. And we have modeled out how this could affect access for duals to different memory care services in a study leading up to the current study. And then there's the lack of benefits coordination. I mean, you probably all know, like myself, that navigating your health plan, what is covered, where you have to go for what, and what needs to be prior approved and whatnot, is not that easy, even for somebody who knows healthcare. But here you are with often poorly educated, sometimes cognitively impaired individuals with very little support that have to navigate two separate coverage schemes. So they have to understand what's covered under Medicaid, what's covered under Medicare. The practices have to figure out what whom to bill for what and what is eligible and what's not. And so that adds another layer of complexity that serves as a deterrent for practices to accept dually eligibles. A bright spot in this is that the so-called DSNP plans, the dually eligible special need plans, are designed particularly to address that very problem. They are a Medicare Advantage plan that is only accessible for dually eligibles. And those plans have to contract with state Medicaid agencies as well. So there's easier coordination of benefits than under Medicare and Medicaid separately. And about close to 30% of duals currently receive their Medicare benefits through DSNPs. Very importantly, DSNPs have undergone a big reorganization in the Bipartisan Budget Act of 2018 that effectively of January 21 has set clear standards for how DSNPs have to be integrated. There is the so-called fully integrated dually eligible special need plans, which is called the FIDE plan. And this is literally all Medicare, Medicaid under one plan. So to the practice, the dually eligible in one of these plans looks exactly like a Medicare Advantage plan patient. So they submit one bill to one health plan. The health plan sorts out what is covered by Medicare, what's covered by Medicaid, and submits one check back to the practice. The check might be a little smaller than what Medicare only would pay, but at least all the paperwork, the complexity of handling two different payers goes away. The highly integrated plans, the HIDE SNPs, are pretty similar with respect to the integration of the payment and administration, but they may carve out either the behavioral health component or the long-term care component. And then there's the coordination-only plan that still pretty much look like the traditional arrangement. There's some coordination of benefits, but the Medicare and the Medicaid coverage are still two separate entities. And it's very important that our project coincides with the rollout of this new DSNP rule. We currently have data all the way through 23 for Medicare fee-for-service and Medicare Advantage. And over the next 3 years, we will get more and more data that portray how this rollout of the DSNP rules affects access to memory care for duals. And it also tells us how the different level of integration impact memory care by level of integration, but also compared to Medicare and Medicaid benefits being separated. So just one preliminary look of a study that's currently under review. We looked into the uptake of the annual wellness visit by dually eligibility and by type of Medicare coverage. So it has long been known that dually eligible are less likely to receive an annual wellness visit. And because the annual wellness visit is required to include some assessment of the cognitive state, it is sort of the best funded opportunity for early detection of cognitive impairment. So what we did is we looked into uptake of the annual wellness visit, not just comparing duals and non-duals, but also comparing the two groups by their type of coverage. So we created four groups: duals in fee-for-service, duals in Medicare Advantage, and then non-duals in fee-for-service and Medicare Advantage. And in the graph here, you can see that the difference between duals and others is really entirely driven by a lower receipt of annual wellness visit among the fee-for-service duals. So it's about a 10 percentage point difference, which is pretty large. Conversely, the duals in Medicare Advantage are pretty much on par with the non-duals with about 45%. In this study, we did not differentiate by the type of dually eligible Medicare Advantage plan. So we did not break out the DSNPs here, because this is the first year of full exposure to that intervention. And thus we didn't feel it is sort of the data are mature enough to investigate this. But this preliminary analysis already tells us that there is a benefit of plan-level interventions to improve access for duals. And of course, in later years, we will break down whether there's a difference within the dual Medicare Advantage group and whether the DSNPs actually have a higher rate of annual wellness visit receipt, and also other services for memory care, such as specialty visits, structural imaging, and then ultimately treatment for Alzheimer's disease if properly diagnosed. This is a very data-intense project, as you can imagine. We are using 100% of the Medicare data, 65 and older, from 2017 forward. We have access to the Medicare Data Vault, which gives us the Medicare fee-for-service data with quarterly updates with only about a half-year delay, and then the Medicare Advantage data as soon as it become available. We are also using the NIA-funded enclave, which allows to link Medicare data to national surveys such as the Health and Retirement Survey and others. We have the Medicare and state-specific Medicaid rates for all kinds of Medicare services. We obtained from CMS a database that reports by month the number and type of DSNPs. We use the American Medical Association master file of physician specialties to identify dementia specialists. And then we geocode all the memory care facilities, the specialists, the imaging centers, the infusion sites, and use road network data to investigate whether geographic obstacles to those facilities, like long travel times, create limits to access for duals. And then we have lots of contextual data at the community level on provider density, hospital beds per capita, income per capita, wealth per capita, education levels, to characterize, if not at an individual level, at least on a more granular level, the communities in which the duals reside. So the next steps of the project is we completed the first part where we looked at differential access for duals and non-duals to memory care services overall. And now we are beginning to split up these obstacles to a greater granularity to be able to investigate the differential contribution of administrative complexity, payment rates, and the care coordination part, how they affect memory care for duals. And then we also want to understand state-level factors, such as what I mentioned earlier, driving distance, which could become a problem in the more rural states, and then specialty density, which also tends to be lower in less populated states. The idea is to really generate state-specific policy insights. I've been in policy research for many decades now, and I'm firmly committed to make research actionable and not just interesting for peer-reviewed journals, because that is the only way to improve quality of care. So we want to answer questions, for example, does the lesser off policy and the state payment rates actually impact access to memory care? If not, the answer for a state is surely not to raise the Medicaid rate, because it would just be more expensive but not more effective. At the same time, we might be able to show that the lesser administrative burden under the DSNPs might improve memory care access, maybe even up to the level of Medicare only for dually eligibles, in which case the answer would be a different one. Or if overall scarcity of specialists is an obstacle in a state, the answer is neither, because there are just not enough physicians to handle the entire demand. Thus, interventions like telecare or attracting more providers to less populated areas would be the logical approach. So these results will be presented in papers throughout the project, and then at a policy conference in the last year in our USC campus in Washington, DC. And if you follow us on LinkedIn, you will see both new papers and conference presentations coming out, and then also the announcement and invitations to this policy conference in about 2.5 years. So as I promised, I kept it short, and I'm happy to take any questions. Yeah, detection rate above 120%. So the question is why the detection rate for dementia in Medicare only was 100%, 120% as opposed to 100%, which means over-detection. The detection rate is calculated with two components. We have a statistical model that predicts an individual's probability of having dementia in this case. And the sum of the predicted probabilities is the expected rate or the expected number of dementia cases in a given population. The the diagnosed rate is the count of the individuals who have dementia based on their claims history with dementia diagnoses. And we used in the previous study the then valid algorithm of the chronic condition warehouse that had two flaws. It looked at 3 years of claims and sort of counted up the number of claims with a dementia diagnosis. And it also used a few diagnosis codes that are not really dementia, like delirium and others. So in the current version of the algorithm, they reduced the observation window to 2 years, which tends to reduce the false positive rate because there are fewer, say, spurious diagnoses where somebody suspected dementia and wrote it in because a physician wanted to rule it out, and then the neurologist said, no, we tested the patient, there's no dementia. So, but still the claim for potential dementia might be in the record. And if you have one or two of those, you were picked up by the algorithm. That algorithm, when it was changed, actually pushed the detection rate below 100%. I think it was about 90%. So apparently there were quite a few false positives in the number of diagnosed patients, so that the diagnosed rate was above the expected rate. Does this answer your question? So the question is about New Mexico, general scarcity of specialists like geriatrics, neurology, and even primary care. And what's the situation if physicians do not accept any patients, period, irrespective of insurance? And yeah, this is a problem that's well known. We don't have enough physicians in the US overall. If you look at the G7 countries, like the largest market economies, the US has among the lowest rates of physicians per capita. that often surprises people since we spend so much on healthcare, but we spend a lot on procedures and technology. We don't spend enough on physicians, and we definitely don't train enough physicians. So there's a general problem, not just in New Mexico. And then historically, particularly geriatric neurology, geriatrics have been pretty small specialties because there wasn't that much you could do when you diagnosed a patient with dementia. Yeah. You could stage the patient, you could inform them about what the prognosis is and what the time frame is in which decline will occur, but you couldn't really do much about it. And those specialties tend to be not very attractive to physicians because A, it's not that gratifying to just diagnose a condition and then tell the patient that you can't do anything about it. And it's also less well paid because you have to spend a lot of time with patients and their families, and time and talking to patients and families is poorly reimbursed. I mean, the latest Medicare billing update has shifted a bit better payment rates to primary care docs and a bit less to specialist proceduralists, but there's still a substantial gap. And so, yes, it's everywhere we have a problem that these physicians that don't conduct procedures are just more scarce. This is a problem that unfortunately we cannot really fix because I cannot grow any physicians and put them into Albuquerque and Santa Fe. So the only pathway to improving the situation is, especially for Medicaid patients, to allow them to see physicians outside of the state, which is often not possible. Or to recruit more patients into New Mexico that actually are committed to stay there. But I understand this is a hard problem because now there's a competition all across the nation for these dementia specialists as memory care gets more procedural, and it is actually very hard to attract even new trainees because everybody wants them. So unfortunately for that problem, we don't have any great solution, but I hear your pain, and it's not that you're the only state who has that situation. Next question is why the uptake of the disease-modifying treatment is relatively low. It is not unknown that innovation in medicine diffuses rather slowly. We know from technology diffusion that uptake of new technologies usually follows a sort of S-shaped curve, where you have initially a relatively low uptake by innovators and early adopters, and it takes a few years till you get to the sort of steeply ascending part of the S-curve, where sort of the early and then the late majority begins to adopt, and then it sort of fizzles out. In medicine, this curve tends to be a lot more stretched than, for example, in technology, as you've seen in the rapid uptake of smartphones. We are usually talking about 10, 15-year horizons before such innovations get mainstream. And here in memory care, you are dealing with a completely new situation. Like I always said, the approval of the first dementia treatment for Alzheimer's disease is kind of before and after birth of Christ when it comes to Alzheimer's disease care. Because you had a discipline that was mostly concerned about diagnosing, staging, and advising patients. And all of a sudden, they have to become a highly medicalized discipline that does like biomarkers, spinal taps, high-end imaging, infusion treatment, complicated differential diagnoses. And so these treatments are being launched in a completely unprepared delivery system where really only the clinical trial centers are familiar with these drugs. And obviously a clinical trial center in an academic medical center isn't really a way to scale a treatment for population level disease. And that just plays out in our numbers that the uptake was very, very slow. I mean, we hear from the press releases and investor calls from the manufacturers that it is picking up, but compared to the amount of individuals that could potentially receive the treatments, the numbers remain pretty low. So it's not really one particular barrier of access. It's pretty much similar to launching a high-end oncology care in sub-Saharan Africa. It's exaggerating, but it's similar. People have a drug, but they don't know what to do with it. They are skeptical. Does it work? Is it safe? Which patient is suitable? Should I recommend it? Should I counsel against it? What's the value to a geriatric patient with limited life expectancy of a treatment that requires biweekly infusions and a lot of monitoring visits? So that this is a very complex decision, and not a lot of people are sort of ready to make these decisions or recommend these decisions to patients. And so the default remains inaction, which in my mind is of course a pity, because we could buy patients time with reasonably intact memory and more quality time. So I've written a lot about these barriers, but this is kind of in a nutshell what's happening. That is not unique to the US. The nature of the barriers differs by country. Sometimes countries have more dementia specialists, but more difficulties doing confirmatory testing. But even the high-income countries with very mature healthcare systems have trouble meeting the demand, and hence patients end up on wait lists and can't get treatment fast enough. ECHO program on New Mexico, yes. ECHO is a very impressive program to bring specialty care closer to primary care. It was piloted in Mexico. It was a creation of the University of New Mexico in actually hepatitis C care, when a similar problem emerged, that there were not enough hepatologists who could determine which patient would be eligible for these new curative hep C drugs like Sovaldi. And it also led to wait times, and particularly again in the Medicaid population where burden of hep C was high. And UNMM created the ECHO project that linked up primary care doctors in the community with specialists in the academic medical centers, who would guide them through the decision process with sort of a train the trainer model. So they would learn from the specialist how to detect hepatitis C, how to stage it, what the indications and contraindications for the treatments were, and then sort of made them independent for the routine cases while still having to refer the more complicated cases. And the idea was that one champion in a primary care group would become an expert on that question and then help his or her colleagues to actually also handle at least the routine hepatitis C cases. There is a similar project going on sponsored by the Alzheimer's Association that does do the same for dementia care, because in all honesty, you cannot treat and diagnose a population level disease as Alzheimer's disease solely in specialty care. There are just too many patients to be handled in these practices. So much of the initial workup and triage and priority setting can and must be done in primary care. And Project ECHO is a great way to build the knowledge base in primary care docs, especially in more rural countries where sort of driving 2-3 hours to a specialist clinic is often not a great option. Sort of last call. We've written a lot about these topics, so if you're interested, the publications are on the link that Tabasa just posted. We recently updated them, so everything should be there. And you can also find there updates on conference presentations, and of course then when we have a date and an agenda for the policy conference in year 5. So if there are No more questions. Oh, also, by the way, feel free to reach out individually. Um, we are really committed to helping states deal with this problem. And if there's any information that you need from us, like even data specifically to your state, we're happy to provide those or point you to where you can find them. So if there are no more questions, I thank you for your time, and I hope to see many of you back then in Washington, D.C. in a few years. Thank you very much.